Well, to begin with this week's Cardiology Countdown, I want to encourage you to listen to one of the Heart Minutes on the CRP sub-study from the Heart Protection Study, an important large analysis of CRP and the benefit of statins that Peter Block will discuss. So my number 3 pick is a different biomarker, CKMB, versus troponin in the measurement of Peri-PCI myocardial infarction. This has been a hot topic where we have been transitioning in admission biomarkers to using troponin, but CKMB has been the traditional biomarker with a 3-time elevation diagnosing an MI post-PCI. So a small study of just under 40 patients, and 32 of whom had an MRI done post-PCI to look for late gadolinium enhancement as a way to diagnose necrosis. There were 5 patients out of 32 who had necrosis. Almost all of them were picked up by the troponin elevation, but so were 25 other patients, and so the specificity of troponin was just 22% in diagnosing peri-PCI necrosis as detected by CMR. Now, CKMB did a much better job with 90% specificity, although just 3 of the 5 patients met the criteria of a 3-fold elevation in CKMB. And so the authors concluded in this paper in JACC that CKMB is the better biomarker to detect real peri-PCI necrosis, but I would judge by this small study that further work needs to be done to try and clarify exactly what cut point and what biomarker works best. Now, my number 2 pick is a sobering study on a quality improvement initiative done in the area of appropriate use of radionuclide imaging. This was done at the Mayo Clinic, and thus the single-center quality improvement initiative that focused on physician education, feedback, and remeasurement to determine how many of the nuclear stress tests would fit the appropriateness criteria. They found in the initial 2-year phase of education there was a good deal of reclassification of the events so that there was a fall from 14 down to 7% of what would be deemed inappropriate scans. Then after a hiatus of this education period, they actually found a slightly higher rate, just under 12% rate of inappropriate stress tests. And so their quality improvement initiative failed to reduce the number of inappropriate scans judged by the appropriateness criteria. And so the authors concluded that a more detailed and rigorous program may be needed to help physicians target true appropriate use criteria for imaging. And at the number 1 spot, we have a pair of studies in PAD, where first bit of bad news in a study from JACC comparing women and men and the evolution of PAD over a 4-year period, they found that women had further progression and worse progression to being unable to complete a 6-minute walk as compared with men. This appeared to be due to their smaller leg size and calf muscle size in particular, but certainly a sobering thing for women as compared with men. I want to call attention to the fact there's a good summary of this on CardioSmart, but want to end with good news in this realm where a randomized study compared typical usual care to a supervised exercise program, the standard state-of-the-art approach to exercise training, and a third arm of a home-based exercise program. And this used a novel marker with a meter, a step activity monitor, and then a log that patients would keep and that they shared with once a week and then once every 2 weeks towards the end of the 12-week period with the research associate. And they found improvements in all metrics of exercise duration with either of the two exercise programs, and in particular had very high compliance with the home-based exercise program. And this is one of the first studies to show a benefit of home-based exercise, and so now brings great hope that we can develop home-based programs that can lead to improvements in exercise durations for patients with PAD. This is a very encouraging study, and so we'll look forward to perhaps larger studies and implementation of this to improve outcomes for patients with PAD. So with this week's Cardiology Countdown, I'm Chris Cannon.